Our first topic is toxicology. We'll talk about some of the emergencies that you'll be able to see and take care of. Be able to create a differential diagnosis, formulate treatment, that kind of plan, and then hopefully get a solid understanding of the pharmacokinetics and the various substances and medications that you're going to see. Toxicology is the study of toxic or poisonous substances. Pharmacokinetics is the activity of the drugs in the body over time. And a drug is some sort of substance that has a therapeutic effect, in our bodies, whether that's good or bad, and that there's appropriate doses and circumstances when we use those medications and things. A poison is a substance that can damage structure, impair function of the body. You'll learn that pretty much any medication, anything that we have out there, in too much can be harmful. A toxin is a poison or harmful substance produced by bacteria, animal, or plant, and then overdose is just taking these in excess. And we're going to talk a lot about some of these legal drugs and some of the illegal drugs as well. Some more terms are the bioavailability. This is basically what is actually available in the body once it's been digested and how much is actually used. Half-life is the time needed for the average person to metabolize or get rid of 50% of the substance that's in the plasma. And so that becomes very important, especially as we talk about Tylenol overdoses, other overdoses that we'll have. And so excretion is how we get rid of the body. Antidote is something that we have that counteracts this effect. We'll talk about some of those as we go along. So the types of these emergencies, there's intentional or unintentional. First is, suicide attempt, and second is some sort of criminal activity. Those would be anything like date rape, such as arobohypnol, or sexual assault type things, or also chemical warfare, that kind of thing. Unintentional, this can be many ways. Most often is children who mistakenly take and put either poisons, that being anything from weed and fertilizer, or to medications that accidentally get into. This can also occur in the workplace, especially with a lot of our facilities in and around Cache Valley and Logan. We have a lot of plants. We have a lot of scientific locations, and they do have lots of very interesting chemicals and things that can cause problems for our patients. Poison centers, they're great. The 1-800 number is 222-1222. Many of you have probably used these. By rule, I actually call them almost every time in the emergency room. I have toxicological emergency. Even though I feel like I know what to do on almost all the cases, it's just a great backup, and they're just a good resource. And so there's other different resources. Hippocrates is pretty good that you can use to identify any pills. I don't know if any of you have that. The National Capital Poison Control. This is an online tool and mobile device. It's called basically web. If you just do a poison control, they'll be able to get on there and take a look at that. But the Poison Control Center really is pretty helpful, and they can tell you the bioavailability, the excretion, and the half-life on pretty much any of the medications and chemical substances that you're looking for out there. Every once in a while they won't have it, but it's very rare. I can think of only maybe 3 or 4 times that I've called them and they don't have any information on things that I need. Routes of entry. Ingestion. This is the most common one. Basically people take this, they eat it, they swallow it, that kind of thing. And when we get into all the different drugs, they can snort, they can, shoot it up. They can do a lot of different ways about going about that. One of the things to be remembered, though, is that you're at risk with these routes of entry. Sometimes if it's inhalation injury, we got to worry about some of these, especially like your hydrofluoric acids. We got to control the whole area because the first person that goes in there to help out in certain circumstances can get in a lot of trouble. And so we'll continue at that. But this is where our self-contained breathing apparatuses come in, especially for you. This is so much more important for you in the field than it is for me in the emergency room. In the emergency room, by the time they come to me, you guys have already done so much of the work. And really the most dangerous place for responders is in that initial setting. Inhalation is another one. Again, this is kind of where we talk about that. You really consider the scene safety. And then look for any information that can help identify the toxin. Especially when patients are really, unresponsive, it's really hard to know what it was. And so you kind of try to take a look around and see if you can see anything that might give you an idea of what's going on there. But remember that the gases can be colorless, they can be odorless, and these toxic gases can be really dangerous. And so as we come on the scenes, be very careful. And that breathing apparatus really is truly helpful. I would encourage you to use that in all cases. And then once you know it's safe, then to go ahead and remove it. But I would use it in all cases. Some of the other ones that we're not going to see too much of, the jellyfishes, that kind of thing, but snake bites, wasps, yellow jacket, hornet stings, we see a lot of those. And usually we see them in the setting of anaphylaxis. But, the Africanized honeybees are moving further north. Last I heard, they're in St. George. And so in a year now, we're going to have a couple of these hives around, and so we'll need to be aware of them and how to help out in those situations. Injection. Some poisons are neurotoxic. They produce localized or systemic reactions. You'll see some physical findings on these, their arm, that kind of thing, especially if it's illegal drugs, heroin, cocaine, amphetamines, speedball, those kind of things. That's heroin and cocaine together. You'll see the track marks. They may still even have the needle in the arm. So you should be able to see some of the physical findings, especially of the injection. Absorption. This is one that's more worried about. We got to worry about the decon and the breathing apparatus. Most often, it's the pesticides. The liquid pesticides is the most common, and this usually has a longer time of onset to come in. It's once you're around this, it's just not going to absorb super fast, but it's something we need to be worried of. Toxidromes. Toxidromes are really there's 5 major ones. And this is where you talk about the anticholinergics, the sympathomimetics, the sedative hypnotics, the anticholinergics, and narcotics. And so we'll talk a little bit about these as we go along. But you've heard a lot of these names. But the toxic syndrome or toxidrome is a syndrome-like symptom, and it presents with a similar group of classes or physical findings and caused by a similar group of poisonous agents. And so there's a few of these major ones that we'll see. Truthfully, a lot of these don't present until they've been involved with the situation for a little while. So in the acute setting, in the ER, and as first responders, sometimes we don't see the full toxidrome. I saw a lot of these when I was on my toxicology rotations, especially inpatient and in ICU settings. You'd see them hit full bore, and it was pretty amazing from a pathophysiological standpoint. Pretty sad for the patient. Here are the major ones right there we talked about. You can go ahead and review those. We will talk about some of these as we go along, so I won't spend a lot of time on this slide. Substance abuse. This often results in social stigma in addition to the physical effects that happen. There's a wide and growing variety of substances in use today. It just seems like people's curiosity and people's ingenuity is no end when it comes to drug use. But there's a lot of things that debate exists regarding: is it medicinal, is it recreational, and how do we define what is substance abuse versus what is using a substance correctly. And this has become more and more of an issue as more and more things are legalized in Utah and everywhere else we serve. So drug abuse, we consider this just drugs that cause any harm to the user or others affected by the user, and then we use them not prescribed as a physician. Habituation, this is a dependence on drugs. This is different to me than addiction or abuse. We have some patients that come into the emergency room, they call you, they wake us all up at 3 or 4 in the morning, they need more Norco or they need more Lortabs. And some of these, they're pain seekers, but some of them are just dependent. And so it is kind of a hard thing. But this is that physiological state where they adapt to that drug. The psychological dependence is usually what we deal with most. And this is just their emotional state. They crave that drug. They think they need it. They absolutely think they need it. And these are the ones that always leave the ER really unhappy. Because I'm like, no, you're not getting it. And I'm not going to give it to you unless I see a reason as to why you should have it. And so, anyway, that can be a very difficult thing. And these can be very difficult patients for all of us. Tolerance. This is the adaptation to drug effects. People, you've all heard this a million times. Well, I have a really high pain tolerance. What they mean by that is that it takes a lot of pain medication to help their pain because they have a high adaptation to the drug effects. It's usually, when they say they have a high pain tolerance, it's usually they have a very low pain tolerance. Is my experience anyway. Now we talk about some of the withdrawal syndromes, and this is just kind of laying out again some of the overview of these things. But this occurs after you really quickly stop medications. And you see this most often in narcotics, benzodiazepines, alcohol is a big one. And then some of the drugs that people are prescribed, if they stop taking them, if they're prescribed a benzodiazepine every night or 2 or 3 times a day and they stop taking it immediately, they're going to have some problems. The drug addiction, this is that chronic disorder characterized by this compulsive use of a substance. They just have to use it. It's more than just the psychological. It's more than just the desire. It really, truly is something that drives their entire life. These are most of our folks that we do see fairly regularly, but these most are folks that do end up in jail because they'll be breaking into places, they'll be doing illegal things to try to get those medications or those drugs. An antagonist, this is a drug with affinity for a cell receptor. Basically, say you have heroin that goes and wants to attach the GABA cells in the brain. You can put an antagonist in there that basically will attach to those GABA cells in the brain with a higher affinity than will the heroin. And so that will basically remove the heroin and then it won't be able to be used. That's what methadone does. And that's how we use methadone to help patients. Potentiation. This is enhancement of the effect of one drug by taking it with another. This is where you get, speedballs, for example. People will add things to it. It makes that drug bigger, better, longer, whatever you may think. The synergism, this is kind of the same each situation, but is 2 substances in which the effects are greater than the independent effects. And so both pretty similar, but this is where you get people trying to mix and match quite a bit. So moving on to some of the more, in my opinion, some of the more important things that we're going to do together is the patient assessment. Is first we got to look at the general situation of the patient. What's the mental status? We got to ensure that they don't have aspirate, and if we need to have suction equipment ready. Do they have adequate minute ventilation? What's the overall clinical picture of the patient? Are they unresponsive? What are the vital signs? We'll complete a rapid medical assessment, and we'll try to obtain any history from bystanders, family members. And then if the patient is responsive, we can use our OPQRST. We can do all those other things to try to figure out more and more about what may have happened with the patient. The scene size up. I think this is very important. First, in my opinion, and my nurses will tell you this all the time, I can live with a lot of things in the emergency room, but what I cannot live with is my staff being harmed or being hurt, especially by a patient or by something a patient has done. And so I feel the very same for each of you. I do not want anyone getting hurt. I know we work in a setting where in a lot of ways public views as heroes, and we do a lot of tremendous good. But be safe as you're going and being heroes out there. And so make sure that you're looking at the scene carefully, first and foremost, for your safety. I know that's not what the public necessarily wants to hear. They want to hear that we're going to run in there and we're going to try to save everybody as fast as possibly we can. Be safe doing it. So look for clues also for pill bottles, household cleaners, any handwritten notes. This is a suicide attempt, that kind of thing. Patients who have taken an overdose, they may be very dangerous. They may have wanted to kill themselves, and it didn't happen, they're pretty upset about it. And so be careful. They may attack you, they may attack those with you, or family members around. You may very well need law enforcement to be there. And many times law enforcement is already there and calling us. So just wanted to give you some of the pictures of some of these common drugs, You got some methamphetamine, some cocaine, bath salts, the synthetic cannabinoids, and then ecstasy and marijuana. We'll talk about some of these as we go along. Your primary survey. You want to form a general impression. I think, and a lot of this is going to be very basic to each of you. But identify the concerns of life threats that may be happening there. Really try to rapidly identify, are they going to need rapid intervention? What's their mental status? Is their airway, their breathing, circulation good? By the end of the primary survey, you should be able to identify what's the nature of that illness or what's the mechanism of their injury. And then hopefully we determine the severity of the patient's condition and begin to establish priorities. Basic airway management enables time to obtain this needed information. So that's kind of, I know everything's moved to compression airway breathing now with our codes, but again, this is kind of airway breathing circulation for our toxicology emergencies. We can use a sample history of the OPQRST. I'm not sure which one that you prefer to use. A lot of different ways to go about that. This is just basically using some sort of formula to go through, make sure you're asking similar questions and getting a complete history from them. But really, in the toxicology situation, we know what is the substance and how is it taken. Those are the main things. And then if you can bring to me in the emergency department pill bottles, containers, remaining contents, if they have a safety data sheet, That's going to be your workplace situations. A lot of times they'll have that. And then if you want to just take a photo of a drug label, if you can't take the container or anything that you have there, or even a sample of the ingested material, if it's a plant, if it's something like that, then we can try to do some of the homework as well and try to figure out what they took. So again, kind of history taking, you want to ask them, what was taken? How was it taken? Anything else? Have they vomited? Have they aspirated? Why was it taken? If they have any idea how much, those things are all extremely helpful to us as we continue to take care of them. On a secondary assessment, these are often medical emergencies, and depending on what the toxicology emergency is, it can also be a psychological emergency as well. And so we want to keep a close eye out for that. You want to complete that secondary assessment for every patient that you can. Now, I know time sometimes won't allow you to, and they're maybe unresponsive, so that might be very difficult as well. But in the appropriate setting, we'd love to try to take a look at that. And then we also want to look for any trauma. Sometimes there is trauma in association with these type of situations, especially in the workplace. The chemical reactions, sometimes they're just a pure accident, but oftentimes it's something that's exploded or something that's caused a problem there. So we want to do a trauma-based evaluation on them as well. On your reassessment, you're going to want to continue to monitor the patient's condition. How's their airway? How's their breathing? How's their circulation? How are their vital signs? And we may need to reprioritize depending on how things go along. And then check how your intervention is doing. Have you done an IV? Have you given fluid? Do you have them on a bag mouth mask? What do you have them on? How are they doing? And then we may need to add or subtract as we go from them, as you're en route into the hospital. The emergency medical care, this is kind of the ALS care for toxicology emergencies. It builds on these following: ensure scene safety, maintain the airway, ensure breathing, ensure circulation, and administer high concentration supplemental oxygen to maintain saturation levels of 94% or higher is what ALS guidelines would recommend to us. I would strongly consider you looking at this of establishing vascular access. Consider administering an antidote. I am not totally sure about what all antidotes you may or may not have on your rigs. That would probably be, in my opinion, something where you want to call the online medical control to take a look at. I've been reviewing all the protocols as I've been going along, but about a month in, and so I've reviewed most of them, but I can't remember all of them, so be patient with me. But if we have antidotes and we feel like it's appropriate, it may be something we can use. The most common one that people are using, is to reverse any of the narcotics. I have good and bad feelings about those. I personally, my feeling is to bring people slowly out of an emergency. If they're in a narcotic overdose, usually they're just shallow breathing. I can breathe for them. I can help them do that. I can help administer, a little bit to them slowly and help them wake up. In fact, in Phoenix, when I go down there, I actually just use aerosolized antidote on all my narcotic overdoses. And so some people really love to slam that, get them back, almost make sure that they don't get that high or get what they have there. The only worry that I have that is that can cause some cardiac and some vascular instability in patients. So I would suggest that we kind of go slow with some of those. But I would continue to follow the protocol. And if we think that they're needing it, that we go ahead and administer the antidotes that we do have. But we also prepare to manage for shock, coma, seizures, and dysrhythmias. All toxicological emergency ends with seizure, coma, death. That's how it all ends in all toxicological emergencies. And so we want to be prepared for seizures, for comas, and death, right? But dysrhythmias are huge in this. And so we want to get a 12 lead or get a strip on anyone that you possibly can, and then bring them to us as soon as we possibly can. Alcohol. This is the most widely used and abused drug in the United States, by far and away. Consuming large quantities over a long period of time, that can be very, very difficult for patients. That's when they can get alcohol toxicity. They say upwards of about 27% of adults report binge drinking within the last month. Now that's nationwide. I think Utah's probably a little bit lower than that, but we do definitely have our alcoholics here. Anyone that's spending considerable time obtaining, using, or recovering from alcohol, these guys can easily go into these toxidromes and syndromes, and then especially when they're experiencing social problems, having problems with their family, work, those kind of things. And so that's where we want to try to find out that scene, find out what's going on in their lives, what may have caused them, and maybe they're just drinking significant amount of alcohol because of these stressors at home. The pathophysiology. You get dependence on alcohol, This involves drinking to a function of normally and feeling good. And a lot of times people, that'll make them, they need to do that more and more so that they'll get that same feel-good experience from the alcohol. And so they'll get more and more alcohol into their bloodstream and potentially cause more and more problems. This acts as a depressant to the frontal lobe. So this definitely affects, this says can alter, it definitely affects decision-making process and also decreases the person's inhibitions. When I was in medical school, man, we'd pick up a lot of my fellow students from bars at 2 a.m, and some of the things that they were doing, they would never do that. But their inhibitions were totally gone, and you'd see them acting very different. And then you can get this, the psychological and physical dependence will definitely escalate with how much they use the substance. And then they're also more prone to serious illness and injuries. One of the hard things about both of our jobs is that the patients that we see most often, that come in all the time, that call you all the time, we could name names, but we won't. But those that we see all the time, they actually are a little bit more prone to being sick. And so we got to keep an eye out for them. Some of the things that will happen if they stop consuming abruptly is the minor withdrawal syndrome. They'll be restless, they'll be anxious, they'll have sleeping problems, they'll be agitated, they'll start even having tremors. I look for tongue fasciculations. If they stick out their tongue, you see tongue fasciculations. That's the beginning of those tremors. Sometimes when you have them put their hands out straight in front of them, you'll see their fingers and their hands kind of shaking. That's the beginning of delirium tremens. But until you have a fever, you don't have DTs. And so you can have the tremors, you can have all those things they start, and we can usually reverse those pretty well, besides they have to go to an ICU. The acute alcohol intoxication, we want to assess that airway, have suction available, provide supplemental oxygen as needed, and assist as they need, and then get IV access. Start getting some IV fluid in there, those kind of things to start decreasing the amount of the blood alcohol content that's in the blood stream for the patient. If they're unconscious, that's where we're going to use all that airway and suction and those kind of things. We may very well need to intubate some of these patients as we go along. We want to monitor their EKGs. We want to take a look at their blood glucose level. And then a lot of times I'll administer thiamine if we need to. And then if you want to call me, if somebody's having seizures, that's where the thiamine and things like that come in more often. The thiamine is a chronic depletion of alcohol use. Some of these called beriberi or Wernicke's encephalopathy. These are typically not diagnosed until they've been in for a little while. But oftentimes, to prevent the Wernicke-Korsakoff syndrome, we'll administer 100 milligrams of thiamine IV. Truth be told, if somebody really is truly in Wernicke's, we need about 500 to 600 milligrams of the IV, but 100 is a good way to start. The withdrawal seizures, these can occur within 12 to 48 hours of their last drink. And so we want to use the same care as alcohol intoxication, and then we consider using some benzodiazepines, some Ativan, Valium, those kind of things to help calm them. The DTs, this usually starts 48 to 82 hours after the last drink. They get confused, tremors, restless fever, diaphoresis, tachycardia, often hypotension. This is usually due to the dehydration, as it states there. The fever is the key. You can't actually diagnose DTs without a fever. Most time the confusion is hallucinations. They're usually seeing things. Every once in a while they have tactile hallucinations, but usually it's more of a auditory or visual hallucination for the patient. We want to try to keep them calm, maintain their personal safety. This is really where we want to consider a benzodiazepine. If they're really tremulous, they have a fever, if they're in DTs, we need to get benzos and fluids started as fast as possible and try to keep this ongoing dialogue both with the patient and then also with us as you're coming in, because those patients they're going to end up in the ICU for sure after they've been in the emergency department. Wait, and let me go back. Actually, and that might mean, so depending on what we have, at Cache Valley and at Logan, Logan has an ICU, but it's staffed by internists, not by ICU physicians. And so both of us in a very significant DT's patient may very well be stabilizing and transferring them down to Ogden or Salt Lake. And so this is something that we'll want to be, we'll want to maintain them, continue to evaluate them. You may not only be bringing this to us, but you also may be transferring this patient, have them with you for 2 hours in a transport. And so this can be something we need to really know and be looking out for. Stimulants. There's a lot of different forms of stimulants. Most enhance the release of catecholamines. This basically stimulates the CNS. And so think of basically any stimulants would be like a rush of adrenaline. Okay, so you get agitated, you'll be anxious, you have dilated pupils, You have a difficulty sitting still. You'll be hypermetabolic. You'll be really like sweating, and those kind of things. Now, if you've been doing this for for a long time, you'll be very thin, have track marks. These are patients that are using them as illicit drugs. The cocaine. This is an alkaloid extraction. This was first used as a local anesthetic and nervous system stimulant. If you ever want to stop a bloody nose, give them some cocaine. It's phenomenal for that. But we don't recommend it anymore. It enhances the release and activity of neurotransmitters. And this is kind of the crack cocaine is what's mixed with baking soda and water. And so it's cooked or baked. And that has that crack look to it. So this used to be used historically for elixir of many illnesses. Occasional use of less pure solution, it will not create as much psychological or physiological dependence. So that's why people try to dumb it down a little bit. But this causes serious dependence problems and has significant health conditions. And then usually causes very significant social and psychological challenges with patients. And so we will see a lot of these folks. And they'll become our regulars. Because they tend to lose pretty much everything if they become addicted to cocaine. But really, remember, this is a catecholamine release. This includes norepinephrine, dopamine, and serotonin. The dopamine activity creates a euphoria, and this basically creates this enhanced alertness and tremendous sense of well-being. So that's why people like it. And then the norepinephrine, this results in the stimulation of a sympathetic nervous system, so it gets them like excited. And so it is a hard thing. Once they experience this, they feel like life is just dull compared to what they have been doing. So usually the effects are felt within 1 to 3 minutes of snorted. If it's smoked, 8 to 10 seconds. So that's why people like the smoked and they like the crack cocaine. When the effects wear off, the user experiences a crash, and then they'll often try to use this polypharmacy. They'll want to use other medications to try to keep them up after they've had these problems. And so this affects the depression, irritability, exhaustion. They get this washout phase, what they call when they crash down. They become a hypoactive state. And this is due to lack of neurotransmitters. And it may be very difficult to assess them because they may be very somnolent for us when we see them. Really want to make these overdoses can really lead to chest pain, shortness of breath, diaphoresis, and psychosis. The chest pain is real. It can actually cause STEMIs and STEMIs. It can cause a heart attack for sure. It's a tremendous amount of stress put on the heart. Basically, having them run marathons at a sprint pace is what their heart is doing because of these medications. And then you can get a lot of ventricular dysrhythmias and then myocardial infarction and sometimes a sudden cardiac arrest, depending on what is going on. So really, we want to look for on the dysrhythmias. We're looking for a widened QRS complex or a prolonged QT interval on the EKG. The amphetamines. Methamphetamine is the most common one that we see. Okay, there's a number of clinical applications for these in the past, and that would be nasal decongestants, diet pills, drugs used to treat narcolepsy, ADD, and ADHD. Okay, so we've been seeing these used in schools more and more often for our ADD and ADHD kids and adults. But the amphetamines, the illegal substances, this includes the methamphetamines, the crank or the ice, the MDA or Atom, is the methylene dioxyamphetamine. The methyl dioxymethamphetamine is also, the methyl dioxymethamphetamine. This is the MDMA, the Eve, the ecstasy. This apparently offers an incredible high. And then often this will be tainted with additives. And so usually we're looking at a couple different things that are involved there. But it's low cost, lasts up to 12 hours. This is why we see this most often in Utah and Idaho and Wyoming. It's just cheap, easy to get. And then it lasts for 12 years. And so, or 12 hours, sorry. And so this is why when you go to pharmacies now and you buy it, you buy some nasal decongestants that they want to see your ID, is because this is how it was used to be baked and made. Bath salts. I haven't seen a lot of bath salts here in Logan, but in Phoenix and Dallas, we saw them all the time. Basically, this is a synthetic cathinones. These are psychoactive substances, and they're derived from the cat plant. And they're engineered for this high potency. You can ingest it, insulate it, you can smoke it, you can inject it, and they have some serious side effects. the hallucinations, paranoia, incredible strength, excited delirium. The first time I encountered bath salts as an intern was she had been an 85-pound lady, and she had come in for ankle pain. And I walked into the room, and she was on her gurney, and she was standing up, nude, screaming, "Yahoo!" And I'm going, what in the world's going on? This is not ankle pain. And she had gone into the bathroom while she's waiting to get her ankle looked at, because oftentimes there's an 8-hour wait in our ER to be seen, and she had taken some bath salts. She was probably a 50-year-old lady. Long story short, it ended up taking 6 or 7 of our security guards and myself, nursing staff, techs, to keep her down, to get an IV, to get her calmed down. And I ended up giving her 2 milligrams of Ativan, 5 of Haldol, 3 times. 3 times I gave her that. So 6 of Ativan, 15 of Haldol, and it didn't touch her. And so I had to intubate her, sedate, and basically give her some RSI medications and completely paralyze her. And then she went to the ICU, kept her paralyzed till the bath salts wore off. So, the management of these abuses, you want to establish and maintain an airway, give oxygen, establish IV, and then apply an EKG. Again, widen QRS, prolong QTC. That's what we're looking for most often. And the most life-threatening presentations is dysrhythmias, a vascular event, hypotension, hypothermia, and coma, seizures, death. Now, these patients are usually very agitated, so please be careful yourselves while you're taking care of them. If you need to call police, call police. Don't rush in to take care of them. I don't want anybody trying to wrestle them to the ground or trying to get them to get cared that way. Make sure that you're safe. Once you've got an IV, we can administer benzodiazepines, help them, serial fluid infusions. For violent behavior, we can follow some protocols. You can call your online medical control, and we can offer some of those things to help you out with there. And then we'll get them transported to the ER in both cases, and then we may need to transport them to a higher facility. Often they're going to be hyperperfused, as we talked about. They're going to need this fluid resuscitation. So I'd start, a liter on most of these patients as you can, and then the QRS or the cardiac dysrhythmias. We're going to treat all these chest pains as acute coronary syndrome. Go ahead and give them the aspirin and start them down that protocol if they're complaining of significant chest pain. Treat them like they're acute coronary syndrome, because many of them may very well be. I've seen acute coronary syndrome from people taking too many Red Bulls to people being on cocaine and everywhere in between. So, and then benzodiazepines, as we can use those as we need to. But you could sure administer some sublingual nitroglycerin every 3 minutes, as long as the blood pressure is greater than 100 on the systolic. Aggressive cooling may be indicated. Some of these patients will come in, they'll be very hyperthermic, and so we'll kind of take a good look at that, especially in the summer months. So we can try to cool them the best we can. I'll use that oftentimes in the emergency department with ice, but often we'll spray and then put a fan on them. That's the best coolant that we have for them. But oftentimes you're going to see these patients are going to come in there and exhibit very bizarre behavior. They're going to be found naked sometimes. They have a history of noncompliance with psychiatric medications. They just run very closely together. And so as you're going through your resuscitation of the patient, this is more for me, but maintaining urine output and aggressive fluid therapy, really just hang that leader, get it rolling, and bring him in. If the patient has a seizure or pharmacological intervention, we may need to use that. Again, that's going to be benzodiazepines. Marijuana, cannabis. This is going to be becoming bigger and bigger in our daily practice. We're going to see this more and more often. What you're going to see in transport most often from this is something called hyperemesis that they get from smoking the cannabis. Most of your patients that use this do not believe in this. It is a real thing. And they'll come in and they look horrible. They'll have vomited hundreds of times. They'll be totally hypotensive and they'll look terrible. I've had these patients many times in the emergency department, and I will use everything I can use, from Zofran to Phenergan to Compazine to Reglan, and none of it touches the emesis. They'll just vomit through all of it, and they all have to be admitted into the hospital. And it takes a day or two till that cannabis goes out of the system, and then they finally get back to some sort of normalcy in their life. A lot of times you'll see this as they use this, they'll have some short-term effects of the tachycardia. They'll lose their balance, and they'll have an increased appetite. And so my big joke is that when I want to get ready to retire, I'm going to open up a dispensary, put a Pizza Hut right next to it, and then a gas station on the other side, and then I'm going to have a little clinic on the other side of that, so I have to walk in between those places to get the dispensary. So just kidding, I probably won't do that. Assessment and management. The effects are usually not life-threatening. Usually it's just emotional support and supportive care is what's required. And then we may need a benzodiazepine to help them decrease from the anxious. Usually this is with our novice users at the very beginning. They become very panicked or anxious due to the euphoria and the difficulty with their coordination. It's an odd feeling, I think, for most patients when that happens. And so we'll want to keep an eye on that. Now, sometimes our pediatric patients, they may experience more serious signs and symptoms if they accidentally ingest an edible food source. These are the patients, we don't see this too much here, but if somebody makes some brownies at home and a kid finds it, or there's the lollipops and then gummy bears that patients sometimes will get. In a lot of our big cities where they're drug dealing frequently, this will happen to their patients. We don't see this too much here in Logan, thankfully. Some of these marijuana cannabis compounds, spice, this is a synthetic cannabinoid, and this may contain various chemicals. So we want to be on the outlook that this may have something very different than just marijuana in it. And patients will feel different. A lot of times they'll come into me and they'll say, I took some spice and it just was totally different than before. And that means whatever they cooked it with, whether they made it with, or they split it with, is just very different. The hallucinogens. These are very different. I don't see a ton of these up here. The LSD, PCP, ketamine, but ketamine is being used more and more for depression and treating other things. So we're getting more and more people coming into the ER asking for ketamine. And interesting enough, the medical profession is pushing us to use ketamine for pain control, which I'm not sure I agree with, just because then all of a sudden people are addicted to ketamine rather than addicted to opioids. And I'm not sure which one is the lesser of two evils there yet, to be honest with you. But they're pushing ketamine more and more at this point in time. But experience is affected significantly by if they've used it before or if they have other previous drug experience, how much the dose is taking, what they expect in the social setting that they're in. So that can basically mean if they're taking it in a social setting where they expect to have this great experience and to be with their friends and to do something, and it doesn't turn out that way, they become very upset and very frustrated. Often, depending on if they use it multiple times or not, it'll affect how significant the effect is for them. And so the first time or second time users, everything is brighter and louder. And so when you come to get them in an ambulance, the sirens and the bright lights are going to be very disturbing to them. Any movement in the cab is going to be also very nerving to them. So this LSD is derived from a fungus. What you're going to see is mild tachycardia, palpitations, and mydriasis. That's what you're going to see. Usually the onset's in 30-60 minutes, and it can last up to 24 hours. And so LSD was huge back in the day. It's not as big as it used to be because it's harder to make, and it's actually kind of expensive compared to the other things. Treatment is supportive, and then limit sensory stimulation as much as possible. Everything's going to be very, very sensitive to them. And so we want to try to get them in a cool, quiet environment as soon as possible. And then the primary support is what we're doing. The PCP, typically smoked or snorted, this can be dangerous. They display extraordinary strength. They have a sense of invincibility and seem to lack any awareness of pain. Man, I have seen people just tear up emergency departments. I remember in the county hospital in Phoenix, we had a guy come in on PCP, and the guy had to weigh 250 pounds with sheer muscle, and he just destroyed our ER. It was pretty impressive. But after a number of IVs and a bunch of Ativan, he finally calmed down. And he had to go to the ICU too. So these can be very dangerous, but PCP we don't see too often. For the most part, you have to give an intramuscular sedative just to get them to calm down. And that's what we had to do. We had to do that 3 times just to get them to even calm down enough to be able to help them out with anything. Often once they calm down a little bit, we got to really monitor the vital signs and then high flow oxygen. And so this is going to be one of those that I think you're probably going to see, and you'll be like, holy mackerel, if this is really a PCP and they're in Smith's tearing up the place or whatever, you're going to be on the phone with me and we're going to be like, yeah, get them whatever you can IM to get them calmed down because they're tough. Ketamine, at low doses, you get mild inebriation, euphoria, and increased sociability. At higher doses, really bad nausea, difficulty moving, complaint of entering into another reality. This is that dissociative anesthetic. And so they actually become dissociated from where they are. and this is my concern with using it so much, is that because it dissociates people, the effect is so significant that that's what they want to have. Even in these mild doses, I've heard of people going in for their depression treatments and coming out saying, yeah, it really is different. And so I don't know. I'm not sure where this is all going to go, but right now it's increasing usage. I do like it for RSI and those kind of things. Very similar things. Secure the patient well, ABCs, oxygen, IV, and safe transport. Peyote and mescaline, we don't see this very often here. This is something we see a lot in Native American tribes and in the southwest United States and Mexico. It's been around for thousands of years. Dilate people, increase pupil rate, mild hypertension, increased body temperature. It gives you this distortion of time and space. Sometimes it flashes color, out-of-body experiences, and hallucinations. And so people use this quite often. Same thing, very supportive, what we were going to do to get them, and same thing I can do in the ER. The mushrooms. The old joke from toxicology goes, and it's a bad joke, so sorry, but there are old mushroom pickers, and there are bold mushroom pickers, but there are no old, bold mushroom pickers. What that means is there's a couple of these mushrooms that look great, but they'll kill you. But some of these cause hallucinogenic effects, and this is what the psilocybins do right here. Usually 30 minutes to onset, lasts 4 to 6 hours. Vomiting, you'll get dilated pupils, and you'll have some mild tachycardia. Usually not too harmful, but ABCs, monitor transport, IV access. The sedatives and hypnotics. Again, these decrease the CNS, anxiety is reduced, used as a sleep aid. So use these for quite a bit. There's a high potential for abuse in these. This is the barbiturates, is one of the classes. These are actually, they have a lot of different ways to use these barbiturates: long, intermediate, short, and ultra short. And these are what we prescribe a lot as physicians, and people use these quite a bit. One of the things is the dose increases, patients become more and more lethargic, and they have an increasingly lower level of responsiveness. So we'll see this quite often. You will see nystagmus, ataxia, and slurred speech and associated with this on your physical signs. That may be a tip-off that this is what they're using with the barbiturates. Very much like alcohol intoxication. You're going to want to use some pulse ox and capnography if you can as you monitor their oxygenation, and airway is always the first. That's the first thing with the CNS depressions, the barbiturates, the alcohol, is we're looking at that CNS depression and airway. Are they going to vomit? Are they going to aspirate? And can we get proper oxygenation? Management, if shock develops, we might need IV fluids, and that really is if they become hypotensive. If they go through minor withdrawal, what we'll see oftentimes is restlessness, tremulous, insomnia, diaphoresis. Again, just like alcohol withdrawal. So these are very, very similar. And then the IV route is preferred in the pre-hospital setting. That's where we kind of want to start with anything that we're going to use, especially if we're going to use any of the benzodiazepines to help them. That will help sedation and reduce the anxiety for them. Benzodiazepines. Sorry, I was messing up. I was still thinking barbiturates. I apologize. Okay, so benzodiazepines. We see these often. This is your lorazepam or your lorazepam and Valiums, those kind of things. Okay, ultimation, drowsiness, slurred speech, and then incoordination. Often see these folks come in and often administer medications to them. One of the things that they say on the overdoses of these medications is nobody dies from benzodiazepine overdose unless they choke on the pills, right? Because it's just as respiratory depression. We can manage all the airway. We can manage the oxygen. We can get IV things, EKG and pulse ox, those kind of things. We're going to want to have all those, but very rarely do they actually have a problem with that. We used to consider activated charcoal. Very rarely anymore do we use those. Sometimes we'll use flumazenil, and this is the antidote for it, or romazicon. That will sometimes use. I've used this very rarely. I think I've used it maybe 5 or 6 times in my entire career. Narcotics, opiates, and opioids. This is where we see most of our things. This is where you see most of everything. This is where I see most of everything. The narcotic, these are the acts as CNS depressants, produce instability and stupor. Opioids, these are natural drugs derived from opium. Opioid is a non-opioid derived synthetic. Okay, and that's kind of the basics of those. These produce analgesia and euphoria. So people like these for their pain medications. This is what people like about it. The euphoria is what they like, and it takes away their pain. This is why the high addiction rates to it. You'll see the euphoria, the hypotension, sometimes respiratory depression, and pinpoint pupils. Those are the most common you'll see. Now, they can also cause nausea, vomiting, and constipation. That's what I get people back in the ER from after their surgeries. Yeah, shoulder surgery, and 5 days later they're constipated and they come back and see us. And that's kind of the most common presentation we see in that situation. You can use the naloxone on these guys. This is what we were talking about a little bit earlier. If we have to use it, we use it. But I like to go a little bit slow with it if I have the time. But if they are significant and they're not breathing, go ahead and hit with that narcotic or with the naloxone and bring them back. You can go 0.4 to 2 milligrams. And if they're waking up, then that's really great. And that's helpful for all of us. These are just some. This is kind of the pathway that we would use in a severe overdose, life-threatening algorithm. This is back from 2015, though. I believe that's still the newest one. We're looking for the major problems that we see of these cardiac medications. I'm going to go through these kind of fast because we don't see a tremendous amount of these anymore. We see a ton, but basically have antidysrhythmics, beta blockers, calcium channel blockers, the glycosides, and then the ACE inhibitors. Basically, you just want to get a patient history list, find out what they have been taking and how it might be affecting them. There's a couple to go through here, they're the big ones that we'll talk about. But basically, we just want to get any idea of what may be going on. These are ones we always want to get an EKG on. We want to take a look at the QRS and the QT prolongation, and then also make sure there's not hypotensive. If they've been taking too many of these, they get hypotensive, or if they just accidentally mix some medications, we'll see that. And we look for any dysrhythmias as well. The beta blockers, these are probably the most common ones that we use. Metoprolol is a very common one that you'll see patients using this often. They become hypotensive and bradycardia. It acts on that beta response, so it makes your blood pressure go lower and it slows your heart rate. That's what it does. And then in little patients, in pediatric patients, you can get hypoglycemia if they accidentally get into one of these pill bottles. The beta blockers also act on the lungs. So that's where the bronchospasm comes into play. And so oftentimes we can give some albuterol. In the very, very significant ones, we use glucagon as the beta blocker, as the antidote to the beta blockers. Okay, and they may need as much as 6 milligrams to be given. But these are in the severe overdoses. These are the patients where, I mean, to me, when I'm giving it them, they're coming in, you guys are coming in and saying, we found this pill bottle and it's metoprolol, and somebody took the entire pill bottle and they're unresponsive. That's when I'm administering glucagon to help them overcome that, and with some IV fluid boluses. The cardiac medication, the potassium channel blockers, these can become toxic. A lot of the medications that are used to decrease blood pressure block the potassium, and so they'll come in hypotensive, bradycardic, and they can have dysrhythmias because that potassium is so significant on the QT prolongation. So we want to take a look at that immediately. The calcium channel blockers. We are seeing more and more of these because they don't have any effect on the lungs. And so it used to be predominantly beta blockers, but now we're going to calcium channel blockers to see. Again, you can see exactly what you'd expect to see. Decreased pulse rate, decreased AV nodal conduction, decreased myocardial contractility, vasodilation, nausea, vomiting, altered mental status, and metabolic acidosis. And the metabolic acidosis all becomes everything's slowed. You're just not clearing things as well. IV glucagon may help out with this, but we'll use IV calcium chloride or IV calcium gluconate in a very severe situation for these patients. This would be, I don't even think you have any of these things on your rig. This is what I'm usually giving them. But we may need to continue this en route when they're going from our facilities to an ICU with a cardiac center. The glycosides. This is digoxin. Digoxin used to be the best medication to use for cardiac problems. The only person I see, I'm not going to name, there's only 2 doctors I see in the Valley still prescribing this as primary care physicians. Everything's kind of moved away from digoxin, but some people still use it. In acute toxicity, nausea, vomiting, GI distress, and then they can have lethal hyperkalemia. And then we'll give them the DigFab, the Digibind, to get to use these. Usually you don't have this on your rigs. I only have one of these in Cache Valley. I think Logan has 2. And so there's not a lot of Digibind that we have out there anymore because it's super expensive and it goes out of use very quickly. They're going to organophosphates. This is one that you see quite often. These are some of the names of these: the acephate, the azonone, the melathanone. This is your insecticides. Usually you see these in an accidental agricultural exposure or manufacturing, or a little child gets into it, or a suicide. Those are the most common ones. This is the dumbbell mnemonic. Diarrhea, urination, meiosis, the constriction of the muscles of the pupils, bradycardia, bronchospasm, bronchorrhea, so you get mucus in the lungs, and then the emesis, lacrimation, seizure, salivation, sweating. Okay, that's the dumbbells. That's what you're going to see in the full tox syndrome. By the time that you get there, unless they're far along into it and they haven't been found for a while, you're not going to see the full tox syndrome on this. But you will see the muscle fasciculations. You'll see the respiratory distress, and they may be going into some seizures at that point in time. You want to decontaminate before initiating care. You want to establish the airway and IV access. In the severe cases, we want to do IV atropine push. And then prilidaxin or 2-PAM may be infused with normal saline. We'll use that a lot, and that may continue en route as you're transferring for this patient. But administer 1 milligram of atropine IV push in these very severe patients. We want to get an EKG. We want to monitor the pulse ox and the capnography and immediate transport. Carbon monoxide, we do see quite a bit of this. You can see most of these guys. We have a bunch of the chambers over at Cache Valley, so we get a lot of these. In fact, the other night, we had a young man that accidentally started a fire, and it caught all the cottonwood and just caused a real quick fire, and end up causing a big family camping by. It all come in. So we had 12 patients at midnight, all coming in with concern of carbon monoxide poisoning. They all were fine. Really, you got to be enclosed. The house fires, a running vehicle in a closed garage, or use of a gas-powered heater. The question to always ask is, you come to a family and they all say, oh, we all have the flu, we all look bad. Ask them how their dog or cat is feeling. If the dog or cat is sick too, then carbon monoxide poisoning. And this is a suffocation at the cellular level. Okay, they don't feel it. It's colorless, it's odorless, it's tasteless, but it's suffocation at that lowest level. These are the signs you're going to see: headache, fatigue, nausea, tachypnea, tachycardia, confusion. And then what we want to do is basically provide the highest concentration of oxygen that we can. Remove them from the environment and get that airway started. And then high flow supplemental oxygen. For me, if they're really bad, if I get their levels here in the ER, I need to get them there, then I'll put them in the dive chamber. But usually it's just high flow oxygen. You want to just keep them quiet and at rest, monitor EKG. Every once in a while we get an EKG change with this because the carbon monoxide can displace, and you basically get a potassium elevation. You're looking for QT prolongation and QRS widening. The chlorine gas, usually, so the only time I ever really experienced this was when I was a kid, and I was told to clean the bathroom. And as a 14-year-old boy, we didn't clean the bathroom very well, so my brothers and I, we took 3 different chemicals and we put it all in the toilet container because we wanted to get it super clean. Anyway, we basically caused chlorine gas, and it injured all of our lungs, and it hurt, and our eyes were all red and everything. And stuff what you could usually see in the home setting, or you could be in an industrial setting with the faulty valves or pumps and those kind of things. And so you will see this from time to time. Typically, if it's from a large industrial storage tank, this can result in a mass casualty incident. Many people are going to have problems and be exposed to the chlorine gases. Very significant burning sensation in the eyes, nose, and throat. You may have even a slight cough as that gets down and disrupts the bronchial. And then you can get very severe exposure, can cause cyanosis, shock, and seizures. Just like everything else we talked about, seizure, coma, death is what we look for in all these patients with all these toxicological syndromes. Remove them from the area. Deliver high concentrated humidified oxygen. Irrigate the burning and itching eyes or skin. And then anyone that has respiratory distress already, especially if they have asthma or other problems, we want to really look at them really quickly. And if they have any significant respiratory distress as well, I wouldn't play around with these guys. If they have significant respiratory distress, intubate them, RSI, and then transport them. Because their airways can swell up significantly and have a problem very quickly. Cyanide. Again, we don't see this too often. They say it's very colorless and has an almond scent. You can look up some videos, some people committing suicide using these from time to time. I've only had one person with cyanide toxicity, and that was a lady that somehow found it and tried to commit suicide, and didn't. The crew got to her quick enough and gave her a Lily kit, and she actually did well, and came back. But this is death within seconds if inhaled, death within minutes to an hour if ingested. Initially, you can get headache, nausea, vomiting, anxiety, vertigo, weakness, and dyspnea. And then if you do see these, we want to get them, treated as quickly as possible. We need to displace the cyanide from the cytochrome oxidase by introducing another chemical to bind to it. And that's where we get the amyl nitrate, okay? And we take the amyl nitrate kit. If we don't have that, if it's not available, you want to break it, put it in a gauze pad holder over the patient's nose, and monitor the patient closely, and then transport as fast as we can. The hydroxycobalamin, they say, is even better than the Lilly kit, but we want to use this in patients that are hypotensive, ultimate status, or on cardiac arrest after being removed for a house fire. The house fire, sometimes in the furniture, there's stuff that will cause the cyanide to come. So if you have someone that's cardiac arrest or completely unresponsive in a house fire, hydroxycobalamin, and we need to think of cyanide toxicity. The methylene blue, this is an antidote that is used to treat the methylglobinemia. This is what we get with the cyanide. It basically causes our blood to really become meth hemoglobin. It changes our concentration of the hemoglobin in our body, and so therefore we cannot bind oxygen like we should. So we'll need to use the amyl nitrate and the sodium nitrate to get that back under control. Some of the caustics, this is really strong acids and strong bases. This is industry, agriculture, and home settings. Occasionally you'll see these. The really strong ones, they say, are pH less than 2 or a pH greater than 12. These are, you can see, burning, drooling, difficulty talking if they swallow it. A lot of times it's into the eye, and a lot of times it's very, very irritating to the body. You're going to want to dilute as best you can with some milk and water within minutes of exposure, establish IV, and get them transported. And then anything that's dermal or eye, you want to dilute and flush away the substances as best you possibly can. For eye, place the prong section of the nasal cannula on the bridge of the patient's nose, and then plug that into IV administration set and just let that continuously irrigate through. A Morgan lens is something I have in the emergency department. I don't know if we have any of those in our rigs. That allows for initial gross flushing. We also just have our eye irrigations that somebody can just stand underneath and get a tremendous amount of eye irrigation that way. So we just want to do our very best to get them irrigated. In the ER, I actually have what's called like a pH paper, where I put the pH paper on top of their eye or on their body, and it will change the color and tell me what pH that still is. And so I'll irrigate until I get the pH back to normal. And then I'll give it a little bit of time, and then if it changes color again, I'll irrigate until I get that pH to maintain at a normal pH, and especially in the eye, because it can be very toxic. Don't give any neutralizing substances. Okay, if it's an acid, don't give them a base, because what that does is that it produces heat. And so we don't want to mix those two things. It gives you what's called an exothermic reaction, and that can be very difficult for them, especially on the dermal or the eye. That can become caustic for them. But it'll also, if it's in ingestion, it'll cause vomiting. And then sometimes in these situations, we'll do gastric lavage and activated charcoal. These are still listed, but don't perform them in definitely out in the field. I don't think we have any facility to do that out in the field. I very rarely do those. And so we don't want to do any of these four things if we can help it. So we may even give them some Zofran so they don't vomit. That kind of thing is how significantly we don't want this to happen to them, because it will cause irritation to the esophagus as it comes back through. Common household things that may be difficult is for the kids especially, the colorful plants and sweet-smelling cleaners. Kids just, I have a 2-year-old at home. Everything goes into his mouth. He just likes to try everything out. And so we got to be careful for them. Now, here are some of the last few things I want to just buzz through really quick before we get to the end of these things. I know we're kind of running along, so I'm way over the hour mark. I apologize. I'm hitting an hour right now, even with the initial stuff, so I'm sorry. We're going to try to buzz through a few of these things, and I'm learning maybe we need to break this up a little bit. So you guys can pause and take a break whenever you want. But some of the things that we'll see, especially with Utah State right in our back door, some of these things that increase sexual gratification. So the ED medications, sildenafil, tadalafil, these ones can cause cardiac abnormalities and then also priapism. Really supportive care is usually sufficient for these folks. When you're going to see the cardiac abnormalities is you've got an older person using sildenafil, and they're also taking it with a vasodilator. When those two are reacted, it becomes very profound hypotensive, and you'll see them in shock. And we'll just need to pump them with some fluids until we get them under control. The cocaine, the amyl nitrate, the ecstasy, all these things will cause this increased sexual gratification. So you'll see people using this often together. The dextromethorphan. This is found over-the-counter cough suppressants. Again, this is why they make you show you your ID when you get these. But you get hallucinations, loss of motor control, and a dreamlike euphoria. GHB, or gamma hydroxydrubinate. This is a date rape drug. It's odorless, it's colorless, and it usually takes about an hour to take effect. So this is where people slip things into people's drugs or into their drinks, and it will usually produce disinhibition, severe passivity, and then also antegrade amnesia. They won't remember it. And so I've seen this only a few times here in Logan, but you see it quite often in Phoenix, in Dallas. High rate of people putting things into people's drinks or into people's food so that they can then do what they'd like to do to them later, which is terribly sad. But our job is going to be to establish and maintain the airway, monitor oxygenation, minute assist breathing and oxygen, IV access, and provide transport. Rohypnol is another one, known as roofies. This is a very potent benzodiazepine. So it acts the same way as benzodiazepine, but very quick and can be very fast. If it's combined with any other drug, it can depress the CNS very significantly. So you can find these patients unconscious with respiratory depression and even dead. That's how significant the Rohypnol can be. The methyl alcohol. This is formaldehyde and formic acids. These guys are really pretty dangerous. And their peak levels are initiated within 90 minutes or so. And so we'll see them quite often. Most often we'll see this used in suicide attempts, but they'll have significant nausea, vomiting, headache, vertigo, abdominal pain, and blurred vision or blindness. The blindness caused because you get this dilated pupils with sluggish or no reaction, and it actually causes if you actually look in their pupil, it'll be dilated, and it'll also start to change coloration because it actually is a toxic to that area. So with these folks, we want to establish an airway vascular control. We want to take a look at their blood glucose level. We may need to administer some glucose and thiamine if we can get that to them, and then consider some sodium bicarb as well, because they become very acidotic very quickly, and then immediate transport. But for the most part, establish IV access, airway, and then begin fluid and transport, especially in the acute setting. Ethylene glycol. This is a colorless, odorless liquid. Lethal dose is 2 mLs per kilogram, or as little as 150 milliliters. And this is metabolized in the kidneys and the liver, and becomes very toxic very quickly. This is found in antifreeze, coolants, polishes, and paints. And so this is unfortunately a very common suicide modality in the United States. Stage 1, right after ingestion, is depression and intoxicated appearance. They're going to look really drunk, really fast. And then they're going to need nausea, vomiting, seizures, and coma. And then in 12 to 24 hours, they're going to have cardiopulmonary symptoms and possible hypokalemia. And then in the 2-day to 3-day range, renal damage. And that comes in flank pain. They can't urinate or have significant hematuria. And so you'll get a lot of problems there. This also causes calcium oxalate precipitation, and there's a lot of people get kidney stones in association with this. Management is very similar, especially in the acute setting. It's the same as methanol poisoning. IV access, fluid, oxygen, and transportation. May need to do calcium gluconate, and sometimes fomepizole or actual ethanol can help in these patients. But this is what we usually do in the hospital. So we'll work on correcting the acidosis, hydration, and oxygenation. And then sometimes we use a fomepizole or ethanol, and that's just alcohol, just to displace the methanol and the ethylene glycol from where it's at. And so that will be on the transport side for you. A lot of these patients will need to transport them for renal dialysis. Logan has dialysis, but it's only daytime hours, is my understanding. And so anything at night or anything in that acute setting, it will still be transferred down to Ogden or Salt Lake. Hydrocarbons. These you'll see just very rarely, but these are your high schoolers. They're huffing. Okay, high abuse potential, and it's cheap. And this is usually where they get natural gas, cleaning agents, or fluorocarbons. We used to joke around that we call them the silverbacks or the gold nose parakeets, and that was if they take gold colored paint or silver colored paint and huff that. It needs more inhalant because it's a higher viscosity, and so that's what they'll usually buy to get that high. But you want to get them away from the noxious environment, administer a high concentration of oxygen, and immediately get them over to a facility for these folks. But here's a list of most of these hydrocarbons that people use and or abuse. The lower the viscosity, the higher risk of the aspiration will be with these. The low viscosity facilitates the uptake of hydrocarbon by tissues of the CNS, and then it will usually cause some gastric irritation. And this is what we're talking about, the gold and the silver paint that will have them come in. And so if you ever see some kid and he looks like he's super drunk and he's vomiting and he's got like a gold nose, you know exactly what happened. Again, the main things here is ensure proper decontamination, establish and maintain airway and ventilation, administer high flow supplemental oxygen, IV access. You can take an EKG, again, QRS prolongation and QRS widening and QT prolongation. Very similar with almost all these toxicological problems. Okay, now just a few quick hits. Hydrofluoric acid and hydrogen fluoride. These ones are very dangerous, especially to you. So I want to be very careful with these. But the pathophysiology here is you cause a profound hypocalcemia and hypomagnesemia. And this causes a massive release of sequestered potassium. And so this causes very quick coronary problems and myocardial issues. So that's why this is devastating. Even a very small amount can be very devastating for patients. You'll see dysrhythmias, tremors, seizures, CNS depression, acidemia. As this hydrofluoric acid penetrates into the skin, significant local tissue damage and necrosis and significant pain often develop very quickly. Inhalation will cause discomfort, bronchospasm, stridor, and airway injury. And you'll often hear wheezes, ronchi, and crackles. If you ingest it, vomiting, abdominal pain, gastritis, and very significant systemic toxicity in these patients. Assess the area first and foremost. Number 2, manage the ABCs. For ingestion, provide stomach evacuation. If possible, again, that's really hard. Really just dilute with some water or some milk. And then we can administer calcium and magnesium-containing substances. And so this is where I'll get them like an IV administration of 10% calcium gluconate, and kind of get them started. And we'll also take water-soluble lubricant and a 10% calcium gluconate, and we'll mix that together and put that over the local burn. That's what we'll use very often for these patients. The hydrogen sulfide. This is highly toxic, colorless gas with a rotten egg odor. Poisoning usually occurs by inhalation. It affects all organs, but most impact is on the CNS and the lungs. Okay, and so if it's been going on for a while, they won't be able to smell the gas. The low level exposure causes eye, nose irritation, headache, bronchitis. High exposure, seizures, shock, coma, death. Those are what we're going to see most common in these hydrogen sulfide. There's no antidote. Remove the patient from the contaminated area, and management is largely supportive in these things. Again, this is where I need you to take good care of yourselves, make sure that you're okay as you go in and rescue these people. We're going to skip over these oxides of nitrogen really quick. Not too much there. A few quick hits on some of these drugs. Tricyclic antidepressants. We don't see these as much as we used to because the SSRIs are out and the NSRIs are out, and they're safer. But now they're used mainly for insomnia and eating and personality disorders. So you still do see them from time to time. And these are some of the common names of them for you. If it's a toxic ingestion, you get tachycardic, hypotension, hypothermia. Antimuscarinic qualities, they present like an anticholinergic toxidrome. Pretty similar to that. That saying, remember, is hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a hatter. So that's kind of what we see. you're going to see hyperthermia, dilated pupils, dry skin, mucous membranes that are dry, reddened skin, and they're going to be agitated or in some sort of delirium state. This is what we worry most about. Here's an evaluation of that prolonged QT interview and then widening of the QRS. Okay, that's what we worry about. This picture on here shows the prolonged QT. Okay, but the QRS is also significant. You can also get prolonged QR or PR interval. And so these TCAs, this is why they are not used for depressions very often anymore, is because of the multiple problems that they had with heart concerns. But we're going to maintain the airway, administer high flow oxygen, establish IV access, provide continuous EKG monitoring. Again, consider sodium bicarb, and then also manage the hypotension with normal saline. We want to also always take a look at the blood glucose levels, rule out any head trauma, and then alert for any agitation or violence. And then benzodiazepines and intubation are what we need if they're really, really sick. Those are the big things that we're going to use. And then provide rapid transport. Lithium. This is a very common mood stabilizer, mainly for bipolar patients. Because they're bipolar patients, they can be very aggressive and they can be dangerous. So be careful as you're taking care of these folks. It is almost completely absorbed in the GI tract 8 hours after it's ingested. There's a high risk of toxic level and overdose. People take too much of this, it can be very problematic. Usually you can have some sort of nausea, vomiting, hand tremors, excessive thirst, the early signs, and then it becomes worse with ataxia, weakness, incoordination, blurred vision, hyperreflexia, and seizures and coma is what you're going to, is very severe. Your management, again, is going to be established to maintain airway, vascular access, treat any hypotension, obtain EKG, and transport to the facility. Some of the non-prescription pain medications, just because these are the ones that are the more silent ones, but the more deadly ones. Many NSAID overdoses remain asymptomatic. At toxic levels, they can have nausea and vomiting and abdominal pain. And NSAIDs are your ibuprofens, your naproxone, those kind of things that we'll see there. Again, similar pathway, airway, access, oxygen, hypotension, and then sometimes treat with benzodiazepines if they're having seizures, and then Transmin. So, actually, one of the unique things you can get here is what's called aseptic meningitis. They can complain of stiff neck and headache and fever, and discontinuing of those medications usually solves the problem. And just that this is what they'll get sometimes after a chronic high-level usage of those medications. Salicylates, aspirin, okay? This will change based on their age, how much they ingested, how long they ingested. Overdose in kids is usually accidental. In adults, almost always intentional. What you're going to see is ingestion of 150 milligrams per kilogram is mildly toxic. That will produce nausea, vomiting, abdominal pain. When you get to over 150 to 300 milligrams per kilogram, that's moderate, and that may produce some vomiting, some diaphoresis, and some hyperapnea. And then tinnitus is the big thing. They're going to say, my ears are ringing. Anything over 300 milligrams per kilogram is going to have severe toxicity and produce a very severe metabolic acidosis. And so those are going to be really tough to get an idea of what's going on. Those severe overdoses usually cause a pretty fatal event, especially if the patient is unresponsive and they have a high fever and they're starting to have cardiac dysrhythmias. They're very, very dangerous and they're very hard to reverse. Again, our job, establish IV, vascular access, saline for hypertension, monitor carbon dioxide levels, just because that's starting to tell us how acidotic the patient is, if we can. And then, they continue to put activated charcoal in here if instructed. Very rarely we doing this anymore. What they found, honestly, is all pill fragments within about 20 minutes of ingestion. Almost all of them have opened and spilled out. And so rarely do we cause vomiting, put gastric lavage, do charcoal, do a lot of things. We rarely do that anymore just because all that we're really getting out is pill fragments. Unless we see a big bezoar of pill fragments like on an EKG and they're just like a huge fistful of them still sitting there with a bunch that are undigested, then maybe we'll consider some of those things. Tylenol. Tylenol is a big one. And the reason why this is big is because it's silent and it's a killer. And this is something we all need to be very aware of. well tolerated with few side effects. Typically, it rapidly absorbs in the GI tract. Signs and symptoms occur in 4 distinct stages. It's less than 24 hours, nausea, vomiting, loss of appetite, and malaise. 1 day to 3 days, rapid quadrant abdominal pain. It starts to get tender to palpation there. 3 to 4 days, they get metabolic acidosis, renal failure, start having coagulopathies, and then the recurring GI symptoms. 4 to 14 days, either they recover slowly or they die. That's how they go in these acetaminophen toxicities. So that's kind of the way it goes. What we want to do on these is we want to get an idea of how much did they take, when did they take it. In the ER, we can't test it until it's 4 hours. At 4 hours, you take a look at it and we see what their level is. And basically, that's on what we call a normal curve. If that's above it, they're admitted, go into the ICU. If it's below it, we'll usually watch them and recheck it in a few hours. So all depends on if they're above or below this line. And if they're above it, they're admitted, it's done game. They're going and getting cared for. If it's below it, then usually they get to go home at some point in time. But our job, again, is to try to estimate the time of ingestion. And then the antidote is acetylcysteine. Ideally, it should be given less than 8 hours after ingestion. And then we base this off the lab test. That's kind of what we're talking about with that normal curve. That's when we decide to give it or not. But we're going to establish the airway, vascular access, and then consider some of these reversal agents if needed, and then appropriate transportation. So that's kind of a quick overview of toxicology. There's so many other things in toxicology, but these would be the main things that we would see, and be able to take care of in our care and what we're doing there. I'm sure you're going to have a bunch of questions. As we get to the hands-on section, my plan is to come, and we'll be doing at least one technique, probably doing something like intubation is what I'd like to do because of the toxicology. Also looking at some EKGs, and we'll be giving you some case-based studies where I want you to go through and take a look of what you would do for a patient. At this point in time, you may choose to do, and what I'm hoping to do, this was too long of a lecture, so I apologize. I need to shorten it down. But what I would like to do in the future is have a case on each of these lectures to go through and go, okay, you come up on a scene, what do you see here? So as you're in your groups and you're going through these lectures, if you'd like to do that, that'd be just fine too. And I may be able to throw one on here really quick to do that with you. Okay, here we go. So, part 1. You and your partner respond to the local high school for an unknown medical emergency. You are met at the school entrance by the girls' physical education coach, who escorts you to the gymnasium. There, your attention is drawn to a group of young girls surrounding one of their peers who is lying motionless on the floor. Your partner makes room for the two of you to reach the patient. You find a 14-year-old girl lying supine on the floor and unresponsive to verbal stimuli. When you apply sternal rub, she mumbles incoherently. A student steps forward and introduces herself as the patient's best friend. She says that the patient, Julie, had been sleepy all morning, became drowsy during lunch, passed out while getting ready to play volleyball. Here's your appearance. Unconscious, no apparent distress. Response pain stimuli. Airways open, adequate rate and volume for breathing, and radial pulses present. What are your priorities at this point? What information do you need? I want you guys to pause this and then talk about that. Just a few quick points for me. Safety is a main priority at all times. Crowd control might be a factor, so take a look at them. Determine if anyone else is having similar symptoms. Is there something in the environment that might be causing these? Once you're confident the scene is safe, then we can start addressing the patient's ABCs. And then your priorities include obtaining a pertinent information as possible, appointing someone to contact the patient's parents and caregivers. Second is, this scenario emphasizes the need to obtain as much information related to a sample as possible, especially related to the events leading up to EMS being called. Because the patient cannot provide information, your sources will be your friends and the coach. Patients with altered mental status can have a wide variety of problems. And sample, or basically using that acronym, will be one of the keys to providing successful treatment. Okay, you conduct your primary assessment. A rapid trauma assessment reveals no life-threatening conditions. As you prepare to perform a detailed physical examination, you ask the coach to find out if the patient had any relevant medical history and to get a contact number for her mother. You also ask the patient's friend if she knows any information that might be helpful. She says that Julie has been depressed lately over time with her boyfriend, over problems with her boyfriend, and thinks that she might be taking some medications to help her cope. The friend seems to remember something and suddenly runs off. So now we're reevaluating her 5 minutes after. Her skin is flushed, warm, and dry. Pulse is 140 beats per minute. Blood pressure is 88 or 58. Respirations are 10, and O2 sats 93. And you've got her on 12 liters on non-breather mask, supplement oxygen. Okay, what is your differential diagnosis? What do we want to do to help her? What's our next steps that we're going to do? Go ahead and pause this and then talk about that as a group. Okay, just a few things from my end. Although your rapid trauma survey did not reveal any life-threatening injuries, at this point you cannot totally rule out head injury as the cause of Julie's altered mental status. Based on the information you have, other different diagnoses may include overdose, hypoglycemia, syncope, seizure, and infection, among other things. Then now you're going to be going, okay, all right, you're going to be delegated the role of cervical spine stabilization because we're worried still about head injury, potential neck injury there. Patient already receiving supplemental oxygen, so you've already started that. While you perform a detailed physical assessment, you can ask your partner to obtain a glucose level and apply the cardiac monitor. Until you obtain more information, no further interventions are really needed, except for, I would say, maybe get that IV started and start some IV fluid as well. Although you should be prepared to support ventilations if they slow anymore or the oxygen saturation begins to fall more. So we just want to be a couple steps ahead, right? We want to have an IV. We want to know what the glucose is. That's kind of like your sixth vital sign when it comes to toxicology. Okay, part 3. Upon completing your detailed physical examination, you determine that the cause of Julie's altered mental status is a possible overdose. You insert an 18-gauge IV catheter in the right arm and administer 0.4 milligrams of Narcan in case Julie ingested narcotics, but you do not get a response. Your partner begins to prepare the equipment for intubation. You secure the IV line, begin to run a fluid challenge with normal saline, and turn your attention to securing an airway. Under direct visualization of the vocal cords, you insert a 6.5 endotracheal tube. Correct placement of the endotracheal tube is confirmed by auscultation of bilateral breath sounds, bilateral chest rise, and the end-tidal CO2 reading of 37. You secure the tube at 23 centimeters marked at the teeth and ask your partner to ventilate via a bag mask device at a rate of 12 breaths per minute. As you begin to package Julie for transport, her friend returns with an empty pill bottle that she found next to Julie's backpack. In the locker room, the label reveals a prescription for amitriptyline, Elavil, filled the day before. The prescription was for 30 pills. Again, next reassessment. This is time at 10 minutes. Flushed, warm, dry. Pulse of 160. EKG shows possible wide complex tachycardia. Blood pressure 80 over 50. Respiratory is 12. O2 sat 97 on 100% supplemental oxygen via bag malvascular ET tube. Pupils are dilated. And glucose 76. So, given the current situation, should you consider treating the patient on the scene or continue treatment on the way to the hospital? And then should your patient manage, how should your patient manage progress? Now go ahead and pause and discuss this as a group, and then come on back. So my suggestion would be, in this case, it is probably best to package the patient and continue treatment on their way to the hospital. She's going to need some antidotes. She's going to need some significant help, especially with that wide, complex EKG. And we want to get her to where we can get that intervention as soon as possible. She is set for a very rapid deterioration. Even though you've done a phenomenal job this far, she's going to deteriorate even more. Now, the management progress. Maintenance ABC should continue to take priority. Management for a tricyclic antidepressant overdose, such as Elavil, would be some sodium bicarb. So depending on what we have and you have in your rigs, that would be something I think you call your online medical control. We talk about it, whether we can get that in effect now or whether they need to wait. That might be something we need to get to the ER and get that eval as well. Then also keep a very watchful eye on that cardiac monitor. We're worried about ventricular rhythms and the QTC prolongation, and then also the QRS widening as well with these TCAs. Okay, part 4. Now that you have identified the substance that Julie might have taken and have started transport, you contact the hospital for medical guidance. You explain to the emergency department physician what you found on arrival, your physical assessment findings, your suspicion of amitriptyline overdose, the interventions undertaken thus far, and current reassessment findings. The physician agrees with your assessment and orders an IV administration of 50 milliequivalents of sodium bicarb. Flushed, warm, dry, 650, wide complex tachycardia. Blood pressure is returning a little bit, 88 over 56. Respiratory is 12 on bag malv. on bag mask device, and people are still dilated. Last few questions. Can the information you provide to the hospital staff during your radio report make a difference to patient outcome? And are there any potential complications can arise during transport? Go ahead and pause and talk that over. From my point of view, providing that proper information and the information that you've gathered at this point in time is tremendous. Does it not only make a difference, but it makes all the difference. Helping us be aware that we think it's an amitriptyline or TCA overdose allows us to get on call with poison control and with toxicology, allows us to get everything started, get antidotes started, get everything taken care of. It allows that treatment to go without delay. In the case of many drug overdoses, time is very sensitive, and so that very well saves that person's life. Number 8, a TCA antidepressant are extremely toxic medications. Life-threatening events potentially include development of ventricular arrhythmias, seizures, and pulmonary edema. So sound knowledge of the effects of these TCAs and your good assessment skills that you just performed are paramount to deliver this effective patient medication and patient care. And that's tremendous. The more information that we can have at the very beginning, it helps everything down the line. And so that kind of information, knowing that, would save that patient's life for sure. So this ends the toxicology lecture. I hope it was okay. We really appreciate your feedback. As I see you, please let me know how this goes. Sorry, I was thinking this would be about an hour. We're right at an hour and a half. Hope you took some breaks in there. Hope you stretched your legs. Hope we didn't bore you to absolute tears. But I'll be posting soon also the one for OBGYN. Talk to you soon. Thanks so much.